Dr. Mike Cantor grew up in a healthcare home. His dad was a solo practice family physician, and his mom worked in the practice. He developed an interest in healthcare policy from an early age, as he heard his father describe the challenges serving his patients and dealing with insurance companies. As a geriatrician and an attorney, Mike focused on care for the elderly. I met Mike years ago when he was chief medical officer at NEQCA, and we've stayed in touch over the years. He's an expert on the healthcare system, and so I decided to tap into his thoughts about the last year of the pandemic. In this episode of the HealthBiz podcast, Mike and I talk about the impact of digital technologies in bringing healthcare closer to patients, how payment systems are changing to support telehealth and home care, what's new in nursing homes, and how disparities are baked into the system. I'm your host, David Williams, and I hope you enjoy the show. If your business needs strategy consulting support, please reach out to me at dwilliams@healthbusinessgroup.com. We have experience throughout healthcare and life sciences, including with the digital health and home health topics I discussed with Dr. Cantor. Mike, great to be with you today. How's it going?
Going well, David. How are you?
I'm doing well. Listen, we're going to talk a lot about the present and the future, but let's roll things back and talk about the past if you're up for it.
Absolutely.
So, let's say a little bit about your upbringing, your childhood. What were your big influences growing up?
So I'm a Midwesterner by background, born in Ohio, raised in Missouri, until I went off to college in the East. And my father was a primary care physician. And so I grew up solo practice. My mom worked in the practice with him. So it's really a family business.
The classic. Yeah.
Exactly. With, front desk person, and that was it. He took time off actually when I was in high school. He did emergency room medicine so he could work shifts so he could be home more because back then, the pager was being introduced, but if he got a call in the middle of the night, there was a patient in the emergency room, he'd have to get up and go to the emergency room to see the patient, write the orders, and then come back. So that got old, and so he shifted for a little while, and then went back to it after we all went off to college. And I would visit him when I was in medical school and actually see patients with him, and that was just fantastic because he's truly a family doctor. So he would see the grandparents, the parents, and the kids all in the same visit for some of those families. So it just all coming together. And it was a very community-oriented practice. Like my dad and mom would run babysitting classes. They would have like Girl Scout troops come in and teach them how to do babysitting safely and teach them CPR and have like the local firefighter come. And so it was always very much about the community and about really getting to know people and building relationships with people and recognizing that the home is really where the heart is and where health is as well. And so the more home-like you can make your office, the more sort of relationships you can build with people, not just as the doctor-patient hierarchy, the better off the patients are going to be, and the more the better it is for the doctor and their team too, because you become sort of a trusted advisor and part of their family. And there's still patients of my dad's, and he's been dead now for over 25 years, and they're still friends with my mom because that relationship that they formed all those years ago goes on.
That's amazing. So, your dad, as you said, took the full range of ages and conditions, and you went right to the top end of it with the on geriatric side. How'd that come about? What's that about?
Yeah, so actually, I trained in primary care internal medicine, so my heart remains in primary care. Geriatrics is a primary care specialty in most cases. It just tends to be primary care for frail older adults, especially because there aren't enough geriatricians, and we kind of have to focus on those who need the geriatrics help the most. The reason I went into geriatrics, a couple of reasons. One, I like working with older adults. And two, as someone who's both an MD and a JD, so a physician and a lawyer, the ethical issues surrounding end of life care have always been really interesting to me. I was involved in it with my dad. I was his healthcare proxy. And so it's something that I experienced personally relatively early in my life, as well as having studied it even before that time as a law student, did some work in understanding advanced care planning and living wills and all of that. And so it's a situation where the opportunity to really help influence people at the end of life and at the beginning of life, the end of life appealed to me more. And so I wound up, because like working with older adults, I have interest in healthcare policy. And so the decisions we need to make as a society about how we ensure access to care and affordability for seniors and the holistic nature of geriatrics, it very much is a specialty that is not about just diagnosis and treatment. It's about understanding what we call the biopsychosocial model of care. So understanding the physical diagnosis, but also the psychological issues, and also today we call social determinants of health, really being able to understand holistically what matters most for patients and their families and their communities. So it's a broad perspective that I've always felt is more consistent with what people really need and want from their healthcare providers and from the healthcare system.
Now, did you figure out first that you wanted to do medical school or law school, or was it one an outgrowth of the other?
Yeah, so I actually did a combined program at the University of Illinois. And when I went to interview for that program, they asked me the same question. And I said, well, it's pretty simple. My parents said I could be whatever I wanted to be as long as I was a doctor. So
Right.
here I am. And so it kind of wound up that way. And I think that the real reason is that when you think about the things that I was interested in, even earlier in my life, health policy was really important to me because growing up in the family of a solo practice physician who was struggling to take care of his patients. We heard every night at the dinner table about the insurance companies and how they were driving up costs and how difficult it was for patients to get what they needed, as well as for physicians to sort of struggle against some of the health plans back at that time. And so the opportunity to influence not just the healthcare of one patient at a time, but to influence communities of patients through working through health policy, or as an MBJD, you can work on the regulatory side, you can work legislatively, work in the courts. Ironically, I haven't done any of those things except for a brief stint when I was working to write ethics policies at the VA system, advanced care planning, do not resuscitate, informed consent, that kind of stuff. But it opened up a world of opportunity for me and has enabled me to do a lot of really interesting work in a variety of different healthcare organizations.
Where are some of the places that you've been over the years?
So been lucky to work in health plans, great health plans like Bright Health, and also for United, company at that time was called Evercare. Now it's part of Optum, which focused on seniors over 65, many of them living in nursing homes here in Massachusetts and Rhode Island. Others also include the New England Quality Care Alliance, which is the physician network for Tufts Medical Center here in Boston. And that was a great experience, wonderful institution, wonderful team. We grew a network of over 1,800 physicians in and around Boston and in the Metro West suburbs and down south to Plymouth and over to South Coast. And I really enjoyed that because working with physicians on their behalf is kind of what I grew up wanting to do because my dad said, he needed help. And the
Right.
job of the network was to really provide that help. And then CareCentrix has been a great experience for me, different than being on the payer side or the provider side, working to support health plans, collaborating very closely with home health organizations, really focusing on bringing care to the patients rather than bringing the patients to the care. And so that was an amazing experience to see how you can actually scale that and do it in all 50 states and develop new products like post-acute care. New data just out recently shows that CareCentrix is really delivering value and reducing nursing home stays, reducing unnecessary costs, potentially avoidable costs, while making sure that the patients who go home stay home and get healthy.
That sounds like pretty thorough work, and you're just getting started, as far as I'm concerned. So there's more to be done. You didn't run out of things to do. So we're a year plus now into the pandemic. Hard to say, and pandemics don't last forever. So might as well take the opportunity to to learn from where we are. Hopefully, what'll happen is it'll be a distant memory, but we'll have been able to internalize the lessons and do something about them. So just thinking about COVID, what are some of the big picture things that you've seen in the healthcare system as a result of COVID?
Yeah, I think the interesting thing to me about COVID is that it did not really create a lot of the problems that we're struggling with now, but it just completely ripped the Band-Aid off. Any pretension that we weren't aware of certain issues, we can no longer say that. So for example, infection control in nursing homes has been a problem for a long, long time. Every year, 30,000 to 50,000 people would die in the United States from influenza. We thought that's the way it had to be because every year the flu came and people got sick and some people got vaccinated and some people didn't. And older people would die, babies would die. Now we're seeing very negligible influenza in a year when we're actually masking and there's a big push for vaccination. So if we had done a better job of infection control in nursing homes, for example, maybe a lot of those people wouldn't have had to die. That's something that was obvious from a theoretical perspective, but COVID really, we actually have the data now to say, hey, this isn't just theoretically possible. It's achievable if we have this focus every year when it comes to an influenza epidemic. We also have, problems with access to care, disparities in care that, again, deep-rooted systematic racism affecting the healthcare system, just like other parts of our society. And we see very clearly now in terms of the death rates, the problems with vaccination access, sort of the cultural norms, almost a caste system, you might say, which is, Isabel Wilkerson's book of that title, Caste, kind of documents really clearly how race affects the way that people are treated and behave in the United States. I think we see that now in the healthcare system in a way that in the past we might have said, well, we're not sure about this. Now it's crystal clear. There's no question that we have to deal with those inequalities and inequitable access to care to really provide the best care for everybody.
You talk about nursing homes and the ability to prevent infections due to influenza in particular, which will be coming back even if COVID stays at bay. I remember early on in the pandemic when everybody's kind of panicking and really not knowing what's happening, and the big approach was to kind of have these lockdowns, not because we thought it would necessarily prevent COVID, but in order to sort of save the healthcare system from being overwhelmed. And as part of that, it was, let's send the recovering COVID patients to nursing homes, which I think it was pretty apparent pretty soon after, at least in New York, what was going on to those that were paying attention. It's coming up now. What was your perspective on that one?
Yeah, so it's a bad idea to take infected people and introduce them into a place where there are a lot of immunocompromised, frail, weak patients. I mean, people only choose to live in long-term care. Many of them don't want to be there. They're only there because they have to be. Like they're literally too weak physically or cognitively to be able to make it in the community, even with a lot of support. So I think we learned pretty quickly that if theoretically we had had the right infection control procedures in place, so we had cohorted everyone and we had the right PPE and we had really made done testing, if that had been available, we would have been fine. The issue is in the nursing homes already struggling with getting access to protective equipment, not having access to testing, at least early on, and not really knowing just how quickly things were spreading in the nursing home. There was a study that was done about a year ago. What happened in Massachusetts was they wanted to create COVID specific nursing homes because trying to cohort people on different floors, keep them separate is really tough because of the space constraints in many nursing homes. So the state put out a program where there were nursing homes that were only going to take COVID patients and be COVID specific facilities. So there was a facility in suburban Boston. They were going to clear out the people who lived there and move them to different facilities so they could use that one as a purpose, kind of quarantine COVID facility. And they tested everyone for COVID. There were no symptoms. There was no known real outbreak in that facility. And they found out that like 50% of the people who were living there already had COVID, but were not symptomatic.
So it sounds like what happened. This is a matter of kind of the initial surveillance, and maybe the CDC missing out on using the test that was already approved, and so we were just flying blind up to that point.
Exactly. And so if we couldn't identify who had COVID, then you couldn't cohort them, and then you couldn't do the things. You couldn't wear PPE. I mean, you couldn't wear it all the time because you didn't have access to it for everybody all the time. We didn't even know who you should really be cohorting because we didn't have access to the testing. So the nursing homes, we actually, a group of geriatricians in New England, we call it the New England Geriatric Network. We informally meet every couple of months. We have dinner together. Last year, we had a Zoom call in April, realized what was going on in the nursing homes, created a nursing home focused group. We've been able to publish a blog in Health Affairs, basically calling for more input into nursing homes, not just during the pandemic, but preparing us for what comes next. Because all these issues, PPE, staffing, access to testing, making sure that we've got adequate payments for the nursing home, all of that, those issues were there before. They got worse during COVID, and they'll be there after. But without community input, without really thinking about who needs to be in nursing homes and how do we make sure the nursing homes provide high quality, safe places to live for the seniors and disabled people who need to be there, we're going to be in big trouble again. So these are the lessons of COVID that we're going to continue to play out long after the pandemic is under control.
COVID accelerated both good and bad things. On the good side, you and I have been speaking about digital technologies for a long period of time, and there's sort of, incremental changes in utilization, then a big explosion in the past year. As you look back over the year, what do you see in terms of the impact that the digital technologies have had?
I think they've been hugely. There's basically an opening there that wasn't there in the past. So in the past, there were telehealth technologies. So we could have video calls. Now, pretty much everyone who's working has been on Zoom or whatever your favorite video technology is. Back, a year ago, only people who worked remotely or who were techies, used this kind of thing. Maybe you use FaceTime on your phone with your family, but it wasn't sort of a standard part of working. Now it's a standard part of working. It's a standard part of visiting with your family, and it's a standard part of healthcare. And so I think before the pandemic hit, I remember I was talking with some colleagues from Mount Sinai a few months ago. They said in one day they did more telehealth visits in their Mount Sinai facilities in 2020 than they did in all of 2019.
Yeah,
Just to give you an example of the ramp up, and it all happened within weeks because once the lockdowns, as you mentioned a few minutes ago, once those happened, it was clear that they wouldn't be able to get patients in to see them, and they had to have a way to communicate with people. And so the video visits were set up. Working at a health plan at the time, we created the right payment policies to encourage people to provide video visits. We paid the same as we would pay for an in-person visit. CMS, the organization that's Medicare and Medicaid, did the same thing. And so we followed along for Medicare plans, but for our non-Medicare plans, we followed guidance from the states, and we also put in place our own programs to ensure people still had access to healthcare, even if they couldn't physically be there. What's interesting is to ask what's going to stick.
right.
That's going to be very very interesting to watch. And it wasn't just the telehealth stuff; it was also the mobile symptom checker apps. And this is part of COVID. You can't go anywhere now without making sure that you haven't had a fever, you haven't traveled 14 days, you haven't been next to someone who had COVID. All of these COVID checkers basically became the way that those apps became popularly used. And so we've seen sort of this weird thing on your phone where maybe you use it to answer a few questions before you go to a doctor's visit. Now, every time you get near a hospital, it's like you have to do it 3 times, or there's a
Yeah.
lot of this. And same thing for public events now, same thing for going to see your doctor. They're asking you over and over again about this. So these smartphone based mobile symptom checker apps or web based, they are here with us, and I don't think they're going away anytime soon. We may see them go away from a pandemic perspective, but I wouldn't be surprised if now people are familiar with them. It's like, oh, I have a sore throat. Let me go on to a symptom checker app and see, is this, is it just a viral thing, or do I have strep, or do I need to see someone and get a throat swab? Those are the things that can now be addressed through those apps. And I think we're going to see more and more of those as well. I,
So what about, if you think about people all of a sudden couldn't come in, so they're on video, and they sort of, but that wasn't the intent. But now, if you think about it more long term, are there are there other sorts of things that you would have in the home besides a smartphone that's going to enable that to be to have fewer blind spots, and to be able to have a more thorough kind of examination or interaction with the provider?
Absolutely. I think that the use of video chats and the use of voice control devices, especially for older, frail populations, for those who have disabilities, who are visually impaired or hearing impaired or cognitively impaired, having more interaction between the devices so you don't actually type anything or push anything, really, really helpful. And I think we're going to see a lot more of that. My mom is in St. Louis, so she and I don't live close to each other. She has a device in her home. I can drop in on her, which means I can just appear on this little video screen. We can have conversations. If she gets sick, and sometimes this has happened where she's fallen and needs help getting off the floor, when people come to help her, I can see them. They can see me. We can interact and talk with each other so they can get a sense of what's going on. And so those kinds of devices, I think, are with us to stay. Not everybody everywhere has them yet. I'm not sure everybody will even let them into their homes. But for a lot of people, the safety and the advantage of being able to communicate seamlessly is going to make it worthwhile for them to have more of those kinds of devices around.
You mentioned before, a couple of things that happened that led to this, just basically straight up path of utilization of these digital technologies. One was that you just couldn't see somebody in the office, so that wasn't an option. And the second was that payers started to pay for it. And clearly, I think that is, that's a big aspect to it. And talking about what might stick later, there had been reluctance before to provide payment for telehealth. That's changed now, at least for the near term. There's a lot of talk about extending that. Payers, might be anxious about that. And then beyond the kind of the virtual visits, there's also other things like remote patient monitoring that are being reimbursed now. How do we think about that, and how do we make sure this isn't just one more add-on to the cost within the healthcare system here in the U.S.?
I think there are a couple of things that are driving the use of these technologies, and we shouldn't forget that patients want to use these technologies. If you've talked to anyone who has been able to have a visit with their physician without having to take time off from work, drive to their office, find a place to park, wait for them to be seen, go through all the questions, all those other things, it's so much more convenient. It's so much easier, and it's so much better from a convenience and time perspective. A lot of people, for things that don't need to actually be seen, those are great solutions. And I think patients and consumers are still going to demand those going forward. So I think payers will have to pay for that, some of that, just in response to this demand that's now been created and supported because of COVID. I think the issue will become first, who are the right people to have those kinds of visits? We don't really have on the clinical side real clarity yet about exactly which diagnoses, exactly which kinds of patients. I mean, you can probably get 80% of the stuff done that you could do with in person, but that 20% matters,
Yeah.
especially for certain patients. So knowing that and being able to kind of screen people, maybe that's how we use symptom checker apps. Also screen people for, can we deal with this telephonically, or can we deal with it through video, or should you come in for this one? And so maybe that becomes part of the communication between the clinicians and the clinical team and the patient and their families over time. I'd also say that the remote patient monitoring, those kinds of devices, there is payment for them, but it's also the case that there's really needs to be targeting of that for people who are going to benefit from it, because they're still somewhat pricey. There also needs to be workflow change on the side of the healthcare system. Even the video visits, now doctors have time in their schedules for video
Right.
visits. That wasn't the case a year ago. So we need to be able to continue to offer that kind of support and that kind of really showing value for those extra costs in order to continue that. We'll also see that the cost structure, it's much cheaper for us to be on video than for you to have a big office with a big waiting room, take up a lot of space with a big staff. So we're going to see downsizing probably of some of those services on the clinical side, and that will also drop the price. So when the payers say, "Hey, we're going to charge you, we're going to pay you less because your overhead is less," I think we'll see some of that happen over the next couple of years too.
Mike, if you think about it from the standpoint of not just like an individual visit and being able to do 80% of something, but look at it maybe for a patient over the course of a year, and maybe take a typical Medicare Advantage patient who is going to have multiple visits. Do you think about is this patient do they become a video patient? Do they become an in-person patient? Or, how do you think about using all the kind of technologies and modes of communication and visits that are available?
It's a really interesting question, and I think we're going to see it play out differently in different parts of the country and with different kinds of clinics. I was talking with a colleague, Rashika Fernandopulle, who's the CEO of Iora, and he was telling me that they have a Medicare Advantage only practice, and they only take care of seniors. And their data over the last year shows that they have 20 contacts per year. Half of them are asynchronous, which means through email or text, but half are sort of real-time conversations. Of the half that are real-time conversations, about 20% are telephonic, 40% are in person, and 40% are video. So what that means is 60%, when you add up the video and the telephonic, are not in person anymore. And that's very different. Whether that number will hold depends. And of course, for individual patients, it's going to be really different. What we need to do is better quantify and have guidelines and data to show this kind of patient's treated well for this condition in this mode of video or telephone versus this patient who just has to be seen. If you have obviously an emergency, chest pain, shortness of breath, you're bleeding, that's not something you're going to be able to deal with in video. On the other hand, if you have a sore throat, if you have an earache, those are things that may actually be able to be dealt with through video and wouldn't require an in-person visit. I also think for certain kinds of services like behavioral health, video is proven to be fantastic in terms of increasing access and also kind of taking away some of the stigma, I think, in some way, because everyone's stressed out because of the pandemic. So there's no shame in going and getting help. And now you can do it from home on your computer. I think that that's something that's here to stay for us as well.
There've been care pathways for quite some time that might be for a given patient with a given medical condition. I'm thinking that maybe just based on what you're describing on the IORA example, those pathways might expand to also talk about what's the mode of the visit. What's asynchronous, what's in person, what's telephonic, what's video. Would you see that being layered on, or are these separate things?
Absolutely. And I think that's the data, that's the research, that's the evidence base we need to develop. Now that we're doing all these different kinds of visits, we should be able to figure this out. And it may be something where you could apply an artificial intelligence model or machine learning where you could get in through an app. The app could do the symptom checking and connect you by video, or it can say, hey, Mike, you need to go and see your doctor because your abdominal pain is better treated by someone who can lay hands on you. And I think we've learned, it's interesting. I talked to my colleagues who are specialists, colleagues in gastroenterology, the overwhelming majority of their visits, almost all of their outpatient visits are done by video, which I never would have imagined because I used to think you have to put my hands on the abdomen and all this
Yeah.
stuff. Turns out for many, many people, you don't necessarily need to do that unless there's something really urgent or acute that you have to be able to diagnose, and then there's no substitute for laying on of hands. I think there's something about the relationship that's important and the context that matters too. So calling up a stranger, a doctor you've never seen, to have a discussion about some things isn't going to work as well as when you have a relationship. And so I think part of it will be not just the technology, but what's your relationship like with that provider? And if it's a long-term longitudinal relationship, you may be able to do more things in video than you would want to do if you don't know that person, they don't know you at all.
I've been working in the digital health field since well before it was called digital health, and back around 2000, working with a company that was called Healinks at the time of the e-visit. And we talk about, or the web visit, they talk about that it was meant to be in the context of an established doctor-patient relationship, and it could work, that way. And I think that was the general thinking. Now, sometimes now, you're calling people up out of the blue as well, and there may be a role for that. But I think you're right about the relationship is an element that needs to be layered over all of this.
I think so. And I think it depends on the kind of patient, the kind of problem. So some people, if you have an urgent issue and you have an infection and you need something prescribed because the cut on your hand or your arm got infected or whatever, that you can deal with without necessarily having a logical relationship. But if you're dealing with chronic illnesses, and remember the most, 80% of the costs in the US healthcare system relate to the treatment of chronic illnesses, you want to do that in the context of someone who knows who you are, what your baseline is, what's different, how quickly they need to intervene, et cetera. So I think that for longitudinal care, absolutely. For primary care, where that relationship is so critical because the team is so much in the coaching role as well as in the treating and prescribing role, it's really important that you have those relationships to deliver optimal care.
Behavioral health is one that you mentioned, where video in some ways might be better. I've heard mixed things on that. Absolutely, it's something where there's not the laying on of hands, and you've got the stigma, and people might be more comfortable in their home and so on. But I've also heard some concern from clinicians about how the same issues that somebody might have anxiety about going out or whatever, it may actually exacerbate some of the problems, just to say, hey, you don't actually have to move from your bed or your sofa and stay and have your treatment there. I don't know what you've heard about that.
I haven't heard much. I can see where that might be an issue, but usually for those patients, that anxiety or agoraphobia, fear of going out in public, will be part of the therapy. So usually patients aren't disguising that. They're talking about that's because that's the problem that they're talking to the doctor about. What I would say is that the interesting thing is that there've actually been studies. A colleague of mine when I was at Tufts, David Adler, who's a consult liaison psychiatrist, showed that the telephonic visits for certain kinds of psychiatric conditions were actually better than video. Remember that in the old days of therapy, the patient would be on the couch facing away from the therapist. They would not engage with each other visually. They would just hear each other and be in the same space. And so there may be something about that distance, enough distance, but not too much distance, depending on the patient, depending on the diagnosis, where having telephonic may be a better solution or as good a solution as video.
Like, you've been a big proponent of home health care, certainly at CareCentrix, but in your other roles as well. What are you seeing in terms of, some of those barriers that exist for home health services? How have those been addressed during the pandemic, and what do we take away going forward?
So I think there's been a recognition of the value of bringing care to the home. First, because especially in Medicare Advantage and in older populations, people are really scared, and legitimately so, because for them to get infected with COVID is much more life-threatening than for younger people. So we've seen some of the changes that CMS has put in place. For example, even video visits, right now you don't have to have a HIPAA compliant video connection, all the rest of it. My guess is that'll come back pretty soon. But they've been able to make it easier. They've actually lifted some of the requirements in terms of being homebound, limiting it to people who can't get out of their house in order to get visits. It's an interesting question now that's coming up in the context of vaccination. So how can we vaccinate people at home? We don't want to vaccinate people at home who could go to a clinic, but for those who can't or where it's really a struggle, absolutely want to bring the vaccine to them. And so because of the state of emergency related to the pandemic, a lot of the rules have been bent, a lot of things have been waived. And I think we're going to continue to see that in certain areas, because what we're finding is that there hasn't been as much fraud, waste, and abuse, which is always the concern in these things,
Right.
as people thought there might be. Because we're only doing this, the clinicians are really working hard to make sure they're only doing this for people who absolutely need to get that care in the home. Of course, there's an exception to every rule, and I'm sure somewhere out there is someone who's misbehaving and breaking the rules and cheating. But the majority of this has gone actually really well, better than we anticipated. And so what we're seeing now is a growth of a lot of home visiting services, companies like Landmark, Aspire, others that are doing hospital at home and bringing care, acute care into the home, community paramedicine, so sending paramedics into the home to do the triage and some treatments in place instead of having to take the person in the emergency room. A lot of states have lifted the strictures on that so that people can roll that out faster. And companies are springing up to provide those services on a commercial basis to health plans and to providers, or even to private individuals directly all over the place. And so, again, it goes back to, can we bring care to the patient instead of bringing the patient to the care? And how do we pay for it, and how do we do it at scale? And can we use technology to minimize the cost? So instead of having their services, for example, where physicians stay in a central location, but a community health worker will go into the home with a tablet, and that tablet device will be how the patient communicates with the physician. Same thing with the community paramedics. A lot of them are doing that. So using technology with a less skilled, less expensive person actually physically in the home seems to be a model that I think is going to continue to grow and to stay as well.
So, Mike, this has been a fascinating discussion about, the last year, what we take away from it, and hopefully, brighter times going forward. Just last question, any reading recommendations for us, any books that you've been enjoying or recommend to avoid?
So last year, after the murder of George Floyd, I was involved in our company's diversity, equity, inclusion committee, and just really became apparent to me the challenges we face as a society and what it's going to take to make things better. And so Isabel Wilkerson is a fantastic writer, Pulitzer Prize winner. She wrote The Warmth of Other Suns, which I just finished about a week ago. Highly, highly recommended, about the migration of Blacks from the American South to the North and to the West. Tells three stories, and by telling the story of those three people really makes it clear what those barriers were and how they overcame it. And their stories are representative of the 6 million people who moved from the southern United States to the North and the West. And her other book, Caste, which came out a few months ago, highly recommend that as well, pointing out that it isn't just prejudice, it's actually built into the structure of our society, and points out the challenges that we're going to have to overcome in order to continue to make things better.
No, it sounds like some great recommendations, Mike. Much appreciated. Well, thanks for spending time with me today and participating in the Health Biz podcast. It's be fun to get together again when we're all fully vaccinated and can go and enjoy ourselves. But this is next best thing. So thank you.
You're welcome, and thank you for the opportunity. Really appreciate it, and I enjoyed it a lot.
You've been listening to the Health Biz podcast with me, David Williams, president of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.